Chairman, and friends. Aortic aneurysms are challenging for the interventionists and surgeons. A good doctor will diagnose in time, a very good doctor will diagnose and treat, and the best may probably would like to prevent it. Prevention of the aneurysm is possible only when we understand the pathogenesis of this particular pathology at aortic aneurysm. Initiation of the abdominal aortic aneurysm, progression of the abdominal aortic aneurysm, prevention of the rupture, and regression of the abdominal aortic aneurysm all need to be explained through the pathogenic mechanisms. Lots of fund has been allocated in US to study the pathogenesis of aneurysm, and that come under these four headings. What has been understood is clearly the connective tissue biology is altered in the aneurysmal wall. The elastin, collagen, smooth muscle cells are significantly involved in the genesis of abdominal aortic aneurysms. The initiation of the aneurysm is by elastolysis, but the progression is by the involvement of inflammation and immunology, macrophages, mast cells, and other types of cells which accumulate in the walls of the aneurysm. The biomechanics add insult to the main injury. The molecular genetics probably precipitate the events. So the risk factors for aneurysm development seem to be on the surface similar to that of atherosclerosis. But if you go more closely into it, the patients with diabetes seem to have resistance to the development of aneurysm. Similarly, the ethnic groups, blacks, seem to have lesser and less incidence of aneurysms compared to the whites. Is aortic aneurysm equal to atherosclerosis? Because diabetes has been found to be equal to atherosclerosis. But patients of diabetes are not prone for aneurysms. So that means, is it something more? Yes. Lack of a consistent dose-response relationship between atherosclerosis and abdominal aortic aneurysm suggests that the atherosclerosis may not be a causal event in AAA, but develops in parallel with or secondary to aneurysmal dilatation. So now atherosclerosis, as it has been told in the past, has two phases. One is the aneurysmal phase. The other one is the steno-occlusive phase. But now we understand atherosclerosis is not the direct link of aneurysm. There is something beyond atherosclerosis in these patients. The elastin, collagen, smooth muscle cells, and other cells are intricately involved. The inflammatory cell mechanisms transmural, whereas in atherosclerosis it is the intima and subintima is grossly involved. Later media is involved, but here it is transmural involvement of the wall is there with inflammatory cell infiltration. The elastin content gets decreased by elastolysis, and the collagen also is lost or destroyed. Smooth muscle cells show apoptosis, and the MMPs, matrix metalloproteinases, increased in the wall of the aneurysms. There are different types of MMPs available. 2 is the most important, and 9 is the most important. 2 is important in the initiation of the insult. 9 is at the time of rupture. MMP 9 is involved. In between, the other 3, 4, 5 also play a major role in the development of aneurysm. The microfibrillar structure is also abnormal, which is connecting the smooth muscle cells in the medium. The elastogenesis is also abnormal. So there are many different types of products and the cytokines that have been studied extensively. To understand the pathogenesis, they have also used various drug modalities to reduce the size of the aneurysms. For example, propranolol, captopril, but not to regress. The only paper which shows that regression of the aneurysm is possible is C-Jun N-terminal kinase inhibition. This seems to be raised in the walls of the aneurysm, and this study from Japan has shown that aneurysms are regressible. This is one particular study which has got the attention of people across the world, and it was published in Nature Medicine, and future trials in this direction. People are hoping a day may come, the aneurysms may regress. So there are many genetic modalities. DRB1 LLC is a major histocompatibility locus. Thereby we can screen the population at risk of developing aneurysms and take all the precautions. And the whites were found to have 75 to 100% of the whites with AAA showed this DRB1 allele. So the elastin, as we know, is in different layers, that 60 to 80 layers present in the thoracic aorta, and in the infrared light only 28 to 32 layers are there. As the age advances, the half-life of the elastin is only 40 years. We don't get a new elastin with the passage of time, and so people develop elastin, mediate elastolysis leading to aneurysms. So people try to synthesize elastin, and the elastin structure as shown here. And smooth muscle cell regeneration. People are now looking at the possibility of helping in the regeneration of the smooth muscle cells. And as you see the structure here, the structure shows the top portion is the elastin and collagen, the middle portion is the smooth muscle cell, and these are the microfibrils. And as the time passes, the elastin is degraded, collagen is degraded, the smooth muscle cells are destroyed, apoptosis, and the wall becomes, and it results in the development of aneurysm. The newly introduced animal models, elastase models and angiotensin II infusion APOE knockout mice, has given us a lot of insights into the pathogenesis of aneurysms. So this is a typical model which has been developed in the mice. You can see that the aneurysm is developing here. And with this, people have developed different designs of these aneurysms by different techniques of infusion methods and so on and so forth. However, smoking seems to be an independent risk factor for the development of aneurysms irrespective of the atherosclerosis. And it seems to be mediated by the alpha-1 antitrypsin, copper metabolism, and tissue antioxidant levels. So there is another important factor that has been identified. It is the TGF, transform growth factor receptor abnormality. Those patients with TGF-R abnormality are at greater risk of developing aneurysms. Losartan is the drug which seems to be very beneficial in these patients, and it has been proved to be beneficial in animal models, and it is being now tested in the human beings for reduction in the size of the aneurysms. So is there any relationship between the aneurysms and the diabetes? As I said, evidence is significant that diabetic patients seems to have a negative association with aneurysms, and that's the reason why people say it is probably not equivalent to atherosclerosis. Doxy seems to be the best drug compared to the beta blockers in reducing the aneurysmal size, and there are many other benefits shown with doxycycline. Major trials are being underway for the study of the benefits of aneurysm prevention and regression. So, ladies and gentlemen, the understanding of the pathogenesis is giving us new insights for the treatment of aneurysms. A day may come, more medical management, and probably a day may come, a vaccine may be given for the prevention and progression of the aneurysm. Thank you.
Questions from followers? Dr. Ramakrishnan, that's an excellent presentation. Can I ask you, recently in the United Kingdom, the survey suggests that there is a decrease in the trend of abdominal aortic aneurysm incidence as well as rupture. Can you explain anything about that?
Well, I think that may be the one report, what you are suggesting. If you really look at the steno-occlusive disease patterns, cardiovascular prevention, best medical therapies, the overall reduction in the steno-occlusive disease-related mortality morbidity has significantly reduced when compared to the aneurysmal disease. On the contrary, many people feel that the aneurysmal disease we are not able to prevent to the same extent as we are preventing coronary deaths or other atherosclerotic major cardiovascular events. I agree with you that particular report, what you are saying, aneurysms, because if you really look at the small aneurysm study or other trials, the pickup rate is going up and up now because our screening methods are improving, our concentrations are improving. As the number of patients who are under the follow-up are increasing, there is more pressure on the medical fraternity to find out solutions to prevent the progression of these small aneurysms. So that's why probably I would like to see these statistics more in a broader perspective rather than in one or two papers. The aneurysm disease is going to increase in the coming years because we are not taking any effective measures, and we are not sure the current measures which are preventing cardiovascular events, that is steno-occlusive lesions, will be similar for the aneurysmal prevention.
I think there is some suggestion also because many of these patients recently are going through lifestyle management and stopping smoking. And also, they are also on the best medical treatment like losartan, like statins, and they've all been shown to have some effect in the aneurysm development.
Agree with you.
Yeah.
Okay, Mr. Chairman, we're out of time for this particular paper. Thank you very much, Professor Ramakrishna.